Thank you. It's a pleasure to be here, and thank you for inviting me to speak. It was really interesting to hear what Angela had to say. I think many of the challenges are similar in pediatrics, but pediatrics also comes with its own separate challenges. So this was kind of a difficult presentation for me to put together and to decide exactly what to focus on. So I hope I have kind of focused on some important points here. I have no relevant financial disclosures. So long COVID, as we know, are symptoms that persist for 4 weeks or more after the initial SARS-CoV-2 infection. And recognizing and managing long COVID is crucial to improving the patient outcomes and quality of life. And management primarily includes symptom management, rehabilitation, and a multidisciplinary approach to providing care. So the fact that there are multiple symptoms and these symptoms can vary very widely among patients does place a difficulty with diagnosis. And these significant symptoms often have very significant impact on the daily activities, work, and mental health. So long COVID in children and adolescents, there are multiple meta-analyses, and you've also heard since yesterday, is a myriad of symptoms. And this was a meta-analysis of around 21 studies, which showed that the most common symptoms were mood, fatigue, and sleep disorder. So some of the challenges that come with diagnosing long COVID in pediatrics is the symptom overlap. There's difficulty in distinguishing some of the long COVID symptoms from other common pediatric conditions. There is overlap with symptoms of anxiety, depression, or chronic fatigue. And there is a potential for misdiagnosis or delayed diagnosis due to symptom similarity with multiple other conditions seen in pediatrics. And of course, in pediatrics, there's the additional challenge that the younger children may have difficulty articulating their symptoms. So what we see in pediatrics, or even what the research studies pick up in terms of numbers, is a huge underestimate, in my opinion, because many of the younger children are probably not picked up because it's difficult to identify their symptoms. And this leads to underreporting or misinterpretation of symptoms. And plus, we have an absence of specific diagnostic criteria for long COVID. So for the initial evaluation, how does it work? Initially, a pediatrician sees the patient and is worked up for various potential causes. And the familiarity with long COVID varies among pediatricians and even among subspecialists. So then there are pediatric long COVID clinics, but they are few and far between. And the vast majority of the US population actually does not have access to these long COVID clinics. So this is something that has been brought up repeatedly. There is a definite need for more long COVID clinics and more education so the pediatricians could provide this kind of care in the community. And that's something that really needs to be focused on as we go forward. Even within the existing long COVID clinics, they have varied structure and approaches. For example, in Children's Los Angeles, where I am, the infectious disease division is where the patient is first seen. There are other places where there is a neurologist, other places where there's a rehab person, and in places there is an integrative medicine. So I hope that all these long COVID clinics can eventually share practice and define what's best practice and what's working best for the patients, and have like a more structured care which works best. Yeah, and this is probably a dream, but hopefully it will happen sometimes in the future. And what after all this, right? Patients are seen in long COVID clinics, but long COVID clinics as well do not lead to a solution. So what happens after a long COVID clinic? So I have patients come in my clinic, and one of the patient's statement was, "You were my last resort, and you didn't actually fix the problem." Right? And the next I'm going to see a functional doctor who is very, very expensive, and we don't have the financial, but we will do what it takes, right? People are ready to stretch for their children. And so the next treatment is really with functional doctors who provide supplements and sometimes interventions which are not evidence-backed and may be harmful in the long term. But I do see that in a desperate situation, people are trying whatever is out there for helping with symptomatology. So what about past guidance? Multiple institutions, NICE from the UK, CDC, World Health Organization, the NIH have guidance on management of PASC. And PMNR, all of them are adult focused with maybe some few paragraphs about pediatrics. PMNR has quite good guidelines actually, focusing on different aspects of PASC. Like they have guidelines for fatigue, for neurocognitive symptoms, and they do actually have a pediatric guideline as well. So the long COVID clinic in our institution, I just went through this briefly yesterday as well, but the referral comes into our clinic. We accept patients who have had symptoms for more than 4 weeks and who have a significant impact on their quality of life. So they're first seen in the infectious disease clinic by the ID physician and then referred to other specialties as necessary. This is not by any means an ideal setup, and the referrals can they are being seen in an already overstretched system, and the referrals can sometimes take months, in a way defeating the purpose of kind of providing concerted care to these patients. So what do we do in this clinic? We first take a thorough history and physical exam and evaluate for other differential diagnoses. So when this clinic first started, that was in August 2021, I would say that I was extremely concerned about other differential diagnoses. And as an infectious disease physician, a lot of the infectious differentials were what I was considering. And as time went ahead, and I would say at that point, maybe we were over testing and over investigating because we were not so familiar or did not understand the syndrome. But as time has gone forward, I feel that with the experience, it's now much easier to identify a person with long COVID without the need for extensive investigation or for the necessity to exclude a lot of other possible differential diagnoses. So this is from the CDC side, basic laboratory testing to consider for patients with post-COVID conditions. And I can say that almost all our patients have had these tests. Either we do it, or actually by the time the patients come to see our clinic, they have seen a lot of other physicians, and most of these tests have already been done. And I can tell you, in almost 100%, these tests are mostly normal. If I would say that there's one thing which is abnormal in this list, that would be vitamin D, and that I would say is not something specific to patients with long COVID. If we sample people in this room, we will find a definite percentage of people who are vitamin D deficient. These are the next set of investigations recommended by the CDC based on symptomatology. So of course you wouldn't be doing this for all patients, but based on the kind of phenotype that is present, you could move on to this kind of testing. So how do you treat and manage? So like I said before, there are 3 buckets: medical management, a rehabilitation plan, and basically hinges on providing holistic support. So the most important thing is to optimize function and quality of life. And a comprehensive management plan should be based on symptoms and underlying conditions. And it's important to set achievable goals through shared decision making. Because there are so many symptoms, it's important to sit down with the family, the child, and the parents and decide which symptom is bothering them the most, and kind of come up with an approach to how to address that symptom probably first. And then, of course, consult relevant specialists as needed. So if we talk about physical rehab, so customized physical therapy plans can address specific symptoms like fatigue, muscle pain, and joint stiffness. But just as Andrea alluded to, unlike most conditions where you want patients to exert themselves and push themselves to the boundary of what they can do in terms of physical capabilities, post-exertional malaise is a specific symptom which is which is exacerbation of exhaustion, which can be triggered by physical, cognitive, mental, as well as emotional exertions. So I think this is a distinction very important. And so just like Andrea, I want to highlight that it's not only physical triggers. So we have patients in our clinic who go into exhaustion or is triggered by actually spending time with their friends, which is thought of as a pleasurable activity, but that is a social trigger which very often they're not able to take. So really, when you think about cutting down and conserving, you have to think of all these different spheres of your life. And again, I always tell the families to sit down, the parents and the child, and look at what a normal day looks for the child, and then decide what kind of triggers can be avoided. Here again, maintaining like a diary is important, because the triggers that are triggers for one child may not be the same that's for someone else. So it's really important to kind of identify what is this for me. And it's more than the physician, it's really the child and the family who can do that for themselves, and then kind of decide to cut back on all of this. So the post-exertional malaise, the typical way that it happens is after this trigger, the exhaustion can appear immediately or sometimes after 24 to 72 hours. And when that happens, it's confusing. It's difficult to identify what was the trigger. So that's something complicated and difficult to predict and difficult to manage. And it can take variable lengths of time to recover from the post-exertional symptom exacerbation. And this can be very disabling. So post-exertional malaise, like one of my patients was waiting for a day that he felt better and went to Disneyland. And that led to a crash which lasted for a month. So it's easy for us to recommend, please cut down this or make a schedule and don't, but they are growing children and they want to do what other kids are doing. So it is an extremely difficult thing to manage, and especially in the developmental stage for children, I feel the challenges are just kind of magnified so much more. So this is very interesting. Andrea, you had this picture as well with the cell phone battery. Actually, this was I have not taken this from anyone anywhere. It was a patient who provided me this kind of analog as to how they decide. And actually, being in long COVID clinic, we've learned a lot from our patients, what works, and kind of it's a lot of what I do is kind of share that information with other families. So one of my patients said that it's like a battery on his phone, and he decides every morning, okay, how much can I do today? And that leads to how they structure the day. And I think that's an excellent analog and a way to approach how you tackle. So again, the management of PEM hinges on pacing, so breaking down activity into smaller manageable portions, energy conservation, such as sitting while performing tasks, delegating whatever you can delegate using assistive devices. Structured rest periods. And structured rest periods are, again, easier said than done, especially when a child is in school. So we do provide letters and whatever support we can for the school to be able to provide this kind of structured rest periods for patients. And again, any increase in activity should be very gradual. What I say is kind of, if we are increasing activity week to week, maybe aim for 10%, but even 10% can be too much for some patients. And again, a multidisciplinary support, providing a physical therapy and input from psychologists can be very helpful. And there's, of course, other therapies that may be useful. So for a younger child, long COVID can disrupt developmental milestones, and they may struggle with speech and language delays. So speech and language therapy can address these issues and difficulty in speaking, understanding, and improve communication. Cognitive rehabilitation, all of you must have heard this term of brain fog, and it's a problem that's very frequent and seen in a lot of adolescents. And a lot of adolescents that come with this condition at least in our clinic, are previously very healthy children, academically and in terms of sports, performing very well. So this is a completely foreign territory to them and to their families. So they struggle a lot with this symptom. And cognitive rehab aims to improve cognitive functions like memory, attention, and problem-solving skills. And techniques include cognitive exercises, memory aids, and structured routines. Nutritional support is, of course, important, and a balanced diet rich in vitamins, minerals can help mitigate some long COVID symptoms such as fatigue and muscle weakness. And consulting with a pediatric nutritionist. What should I do with that? Okay. I don't know how to make that go away. Sorry. There is a screen. Is this a touch screen? How do you make that go away where it says auto power off?
We don't see that here.
No, but I need to look at my screen. Sorry about that. It's okay, I can manage with the other one. Could we just go back to the previous? Okay. So we talked about nutrition, medications and supplements. There is no evidence-based pharmacological treatment currently available for long COVID, which is a problem. And I hope there will be a time when we actually have something that we can offer. So symptom management is primarily by addressing the specific symptoms and medications that were previously used for that. So pain relievers, migraine medications, antihistamines for allergies, melatonins for sleep disturbances. Again, these just directly target the symptomatology. Vitamin D and B12 supplementation, I usually would prescribe it only if they are deficient on our workup. And various other supplements are used without evidence of efficacy. And we have patients coming to our clinic frequently. They are on up to 6 or 7 supplements. And for a young child to be taking that much medication is a problem. But they're also offered this hope that these, and there are some families who were told that these supplements only work when given together. So that's another problem. So the way I approach it is I usually recommend that families start one supplement at a time, give it some time and see if it's helping. And if not, withdraw it just to make sure that the child is not taking too many medications at one time, which could all be unhelpful. Plus, you don't know the long-term consequences of this on children. So I suggest it's better to avoid a lot of supplements and medications with unknown effects on long COVID. So that's where we really need to study this in whatever way, whether it's through physicians joining and kind of keeping track of these medications that are prescribed off-label, patients contributing to a database, or of course the perfect solution would be clinical trials, but clinical trials coming to pediatrics, I have very low hopes for that, and I hope I'm wrong. But yes, so I would also like, even if the clinical trials are in adults and they have good evidence for some medication, we would be happy to use it in pediatrics. I know Amy mentioned earlier that pediatricians are hesitant to use off-label, and I am one of those pediatricians. And we are just trained that way. We do not take risk with children. So I would continue that way until we have more evidence. So I think really the push is on research, figuring out which of these things work, even if it is in adults. That would give us some level of comfort in starting and trialing that on children. So we come to vaccines. So again, Andrea mentioned this a little bit. This is a meta-analysis of multiple studies. And again, these are not perfect studies. There was some benefit in receiving vaccines in decreasing the long COVID. And the other question that I think about is, what about vaccine after long COVID symptomatology has started? So five of these studies reported on vaccination after infection with odds ratio of 0.38 to 0.91. Again, a very wide odds ratio and difficult to comment. And all of these studies were quite heterogeneous, so I don't think we can make strong conclusions from these studies. I was just curious and looked at our clinic data as well. So in our clinic, we looked at this data on 123 patients. Of these, 33 were unvaccinated prior to long COVID, 30 were vaccinated prior to long COVID, and we had a subset who got vaccinated after the onset of long COVID. So when we look at the vaccinated versus unvaccinated, and because these patients come at different times to our clinic, they are not seen at a set time from their symptom onset. So the way we looked at it is to see that it's 0 to 6 months or greater than 6 months, did it make a difference in the number of symptoms if a patient was vaccinated versus unvaccinated? We did not find a difference in that. The other thing that I mentioned, we wanted to look at what happens when vaccine is given after the onset of long COVID. So if you look at this, 53% of patients who received the vaccine reported no change in symptoms after the vaccine. We did have 44% with improvement in symptoms. So I'm a little bit optimistic about this, and I've seen a couple patients who have been like, oh, I got the vaccine, and in 2 weeks I was all better. Was it because of the vaccine, or was it because they were going to get better anyways? You never know, and that's why you need a clinical trial where you're kind of observing for all of these things. And we had a very small, just one patient who had progression of symptoms. So I pretty much present this information to families, and they can make their decision on how they want to proceed. But it looks like overall the tilt is towards maybe vaccines are beneficial. So they either help or no change in symptoms. So definitely something worth trying. Then we come to low-dose naltrexone. I just said earlier that I'm not comfortable trialing medications, but it's been a long time since long COVID has existed. So I reached out to other people to see what they were doing, and it looks like low-dose naltrexone does have a good safety profile with minimal side effects. So this was one thing that I was willing to kind of try. So naltrexone is an oral opioid receptor antagonist, and is a low-dose naltrexone is used in much lower doses than that's used for opioid dependence or alcohol addiction. And it's believed to work by modulating the immune system and reducing inflammation. It has been used for MACFS, and that's where it's being borrowed from for treatment of long COVID. And there is literature to suggest that there is potential benefits for chronic fatigue, pain syndromes, and cognitive dysfunction. Again, this is not a magic treatment. It helps some patients, but not all. So really it's about, like I said, individualized. Families need to try this and see if it works, and continue only if it's helping. So again, there's no randomized control study, but I want to highlight the study by Hector, who uses low-dose naltrexone for patients in the clinic. And what they found in this study was that it significantly decreased symptoms like fatigue, sleep abnormalities, post-exertional malaise, and unrefreshing sleep. So So we have started on few of our patients, and maybe we can put this data together and report back later as to how things are going. So POTS, again, I think Angela went through a lot of management, but hinges on hydration and salt intake, compression garments, and we refer to a cardiologist for any kind of medications, which include beta blockers, fludrocortisone, and midodrine. Physical therapy is also helpful, along with lifestyle modifications. So long COVID does have a significant psychological impact, and it's important to provide mental health support. So we have social workers as well as mental health support available to patients in the clinic. Educational impact and barriers. This is something which is significantly affects children, and they often face significant educational barriers due to persistent symptoms like fatigue, cognitive impairments, and concentration difficulties. This leads to missed school days and falling behind academically. And this is something which is super challenging to children. And when we talked about kind of avoiding triggers, children who were doing very well academically prior find it very, very difficult to adjust with not doing their best in terms of academics. So it is challenging, and of course there is dismissal from school as well as to the symptoms, because outwardly the patients do look well. So the strategies to support include individualized educational plan, flexible scheduling, and additional tutoring or academic support at their pace. And so it's important to have good communication between healthcare providers, educational institutions, and families. Again, all of these are easier said than done. It's not the easiest to kind of maintain this continuous communication. Social isolation is a big thing. When these children are not able to go to school, or when they fall behind their peers, they may no longer be in that same social group, and it's a huge problem. And due to prolonged illness and the physical limitations associated with long COVID. And these can adversely affect their mental health and development. What are the strategies to mitigate? They include virtual social interactions, definitely not a replacement for other social interactions, counseling, and support groups. Support groups are very useful, I think, but there is, again, even within support groups, there are hardly any support groups focused on children. They primarily focus on adult, and Megan here has the long COVID support families, which also caters to children, which is amazing. And I think, yes, a lot more needs to be done for children with long COVID. So what are the resources and support? Family support is important, because sometimes even within families, there may be some disbelief in one or the other parent about the symptoms. So I think the most important thing is that the family understands this condition and provides support within the family itself. And the community support, of course, is extremely important. This is long COVID families. As I mentioned, Megan leads this group, and it's been incredibly helpful to some of our patients. So what are the challenges? There's limited research. I think we've said this a lot of times. And so there's a lot of gap in evidence-based management, and we need dedicated studies and trials. Okay, so again, a take-home message is we need more research, we need more clinical trials, and so that we are able to offer evidence-based treatment to our patients. All right, thank you. I think I took a lot.